Okay, let's unpack this. Imagine, you're walking into a medical center. Maybe you're not feeling great, maybe a bit worried about something. You're suddenly relying really heavily on other people, right? For care, for expertise. It really makes you wonder, what rights do I actually have in that situation? And, how are they protected?
Exactly. And that's what we're diving into today. We've got these excerpts from the NHRA Accreditation Standards for medical centers. These are, well, they're pretty detailed standards that medical centers work towards to get accredited. It's like a quality benchmark.
And we're focusing specifically on Element 10.
That's right. Element 10, patients' rights. And you should think of these standards less as red tape and more like a blueprint for, well, respect, safety, clear communication.
Okay, so our mission here is to sort of cut through the jargon, pull out the key stuff, maybe some things you wouldn't expect.
Precisely. What rights do you have, according to this document? And interestingly, what responsibilities fall on the patient, too. It's about getting up to speed quickly on what good accredited care should look like.
Right, which you can expect. So let's jump in. Where does it start? What's the foundation?
Well, the standards kick off with this requirement for a documented patients agreement or charter. Standard 10.1.1.
A charter. Sounds pretty formal. What's the main idea there?
What's really interesting is that it's not just a list of what the center must do for you. It frames the whole relationship as a mutual understanding. It outlines both the rights and the responsibilities of patients.
Ah, okay, so setting expectations on both sides. Makes sense. What kind of duties are listed for the medical center?
Well, the source material lists things like maintaining your confidentiality, obviously, ensuring your dignity, independence, privacy are respected. They also have to respect your basic human rights, protect you from abuse or harm, and importantly, encourage you to actually participate in decisions about your care.
Right, so you're an active partner.
Exactly. Not just, passively receiving treatment.
That sounds pretty empowering.
Yeah.
And what about the patient side? What responsibilities are mentioned?
So the charter requires patients to treat staff with dignity and respect, kind of mirroring the standard for staff. And then practical things like showing up for appointments or giving notice if you can't, keeping staff in the loop if your situation changes. And there's a pretty stark point, too. It notes that serious breaches by the patient, and it specifically mentions violence towards staff. Well, that could unfortunately affect their right to be treated there.
Wow, that's direct. That harmful behavior can actually impact the right to care under this agreement. And this whole charter, this two-way document, it needs to be easy to find for everyone, right? Patients, staff, and aligned with national laws.
That's correct. Yeah, it's meant to be transparent, a shared understanding, available to everybody involved.
Okay. So beyond that initial agreement, the standards also push centers to think about the ethics and legal stuff around human rights.
Yes, Standard 10.1.2 requires evidence that the center actively considers how human rights legislation shapes the care they provide. It's not just theory. The guidance points to specific policies and procedures they need to have, all developed with national laws in mind.
Like, what sort of policies are we talking about?
Examples listed include things like policies on a patient's right to refuse treatment, guidelines for healthcare proxies.
Healthcare proxies.
Yeah, where you designate someone to make medical decisions if you can't. Also, rules on accessing services, strict confidentiality protocols, your right to see your own health records, requirements for getting valid consent before treatment, and even policies on taking photos of patients.
Policies on photos, huh? That's a level of detail you might not think about immediately. And these policies, they need to cover what happens when ethical issues pop up.
Exactly. The standards demand documented timeframes for managing and resolving ethical dilemmas, plus a clear process for escalating tricky situations, maybe even up to leadership if needed.
Okay, now let's get into the really practical stuff. Standard 10.1.3 talks about personal dignity in practice, like day-to-day.
Right, this is about the tangible experience. It requires processes ensuring dignity is always respected by all staff. It's not just about big decisions.
So how do they ensure that? What does it look like?
The guidance gets really specific, like staff paying attention to closing screens and curtains properly, making sure washing and changing facilities are adequate and private, checking that clothing is, put back correctly after a procedure.
Little things, but they make a huge difference when you're feeling vulnerable.
Absolutely. And offering options for private space with screens if you're recovering and prefer that. Staff need to be sort of vigilant about potential compromises to privacy or dignity.
And I saw there's even a specific standard just for patient gowns, 10.1.4.
There is. It specifies that if you need to undress for tests or procedures, you should get a well-fitting gown. The guidance details that gowns should be laundered after each use, available in different sizes, and designed to help maintain dignity.
Even if you can bring your own, they have to provide ones that meet these standards.
Correct. It covers what they must provide.
That detail, down to the gown design, really shows how broad their definition of dignity is.
Huh.
Okay, moving on. Standard 10.1.5 talks about recognizing individual needs, especially for patients with special needs.
Yeah, this requires centers to recognize and respond to different cultural backgrounds, spiritual beliefs, emotional needs, physical needs. The guidance lists specific groups needing particular consideration: the elderly, people with physical disabilities or sensory impairments, those with mental health issues or confusion, learning disabilities, and kids and young people too.
So it's really about tailoring the care and communication based on who the patient is and what they need to feel safe and understood.
Exactly that. And the guidance gives concrete examples, like making sure there's physical access ramps, automatic doors, maybe providing escorts if someone needs help moving around, offering information in larger print, or just ensuring staff take enough time to explain things clearly, adapting how they communicate.
That personalization focus is so important. Okay, let's shift to information and communication, some really key rights here. First up, confidentiality. Standard 10.1.6.
Obviously critical. The standards require robust processes, so confidentiality is always maintained by everyone. The guidance gives examples, common sense maybe, but vital to standardize, like being careful with computer screens, mindful of phone calls in public areas.
Right, not discussing patient info where others can hear.
Exactly. Securing electronic data, not leaving written notes lying around. It all links back to their main information governance policies.
Basic trust points, really, but good to have them explicitly stated. What about the right to a clear explanation? And crucially, the right to refuse treatment. That's 10.1.9.
This is huge. You have the right to a clear explanation of your condition, any proposed treatment, investigation, procedure. And it's not just a quick summary. It must include potential risks, alternative options, even the costs involved, before you're asked to agree.
And the right to just say no.
Explicitly highlighted. Staff must respect your right to refuse. The guidance goes further. If you refuse, staff need documented procedures on how to record that decision accurately and what happens next. That might mean offering a referral to talk it over with specialists or counselors.
That really does shift the power, doesn't it?
Mm-hmm.
Ensuring informed choice, respecting refusal. Okay, what about getting your own medical records? 10.1.10 here.
The standards say centers must have published info telling you about your right to access your clinical records. And that info needs to explain how to request them, what you can access, any potential charges. It has to comply with national laws and, again, ties into information governance.
So they have to tell you how to do it, not just that you can. That's useful. Language needs are also covered in 10.1.11. What's the requirement there?
Yes, a specific procedure for meeting the language needs of patients who don't speak the official languages. It explicitly mentions using interpreters. And the guidance makes a really important point.
Yeah.
It's not good practice to routinely use family or friends as interpreters.
Oh, why is that discouraged?
Well, think about it. It could compromise confidentiality, maybe introduce bias, or just put a huge emotional burden on the family member. The guidance stresses that proper interpreter services should be available, matching the languages the center usually encounters.
What about emergencies or like middle of the night situations?
If a live interpreter isn't immediately available in emergencies or out of hours, the guidance says a telephone interpretation service might be used if one exists. But, it adds, a live interpreter should still be call-in as soon as possible. It really emphasizes getting accurate understanding even when it's tough.
That's a vital practical detail for safety. Okay, standard 10.1.16 tackles something difficult but essential. Communicating when something's gone wrong, when harm has occurred from treatment.
Right. This requires a clear policy for how the center talks to patients, families, carers when a patient has suffered harm. The guidance defines harm pretty broadly: significant adverse events, unexpected negative outcomes from care.
And how detailed is the guidance on how that conversation should actually happen? It must be incredibly difficult.
It's quite comprehensive. It requires training for the staff who have to deliver this news, acknowledging it's not easy. It defines who's responsible, how and when the news is given, and crucially, what support should be offered not just to the patient and family, but also to the staff involved. The policy also needs to cover reporting the event, sharing lessons learned to prevent recurrence, and keeping detailed records. It's about transparency, support, and learning from mistakes.
That sounds like a really robust, ethical approach.
Yeah.
Okay, moving beyond just information, what about personal preferences and support? Standard 10.1.7 mentions patient preference for staff gender.
Yes, it says preferences for consultation or care by female or male staff should be accommodated where possible. If it's not possible, they need to tell you why. And the guidance adds that even if staffing makes it impossible, your preference should still be noted down.
So acknowledge it even if they can't always meet it. Makes sense. There's also a standard 10.1.1 about using preferred names and titles. Seems simple but important.
Absolutely. Basic respect, isn't it? Staff need to use your preferred name and title. The guidance mentions starting formally, Mr., Mrs., Doctor, unless you invite them to use a first name or something else.
Simple courtesy but vital. And 10.115, the right to be accompanied.
Correct. You have the right to have someone with you, a person of your choice. The guidance clarifies this could be the person named as your healthcare proxy, or an identified carer doesn't have to be family, just whoever you choose.
You mentioned healthcare proxy earlier. Can you clarify what the source says that is?
Sure. The glossary defines it as a legal thing where you name someone as your agent. That person can then make healthcare decisions for you if you become unable to. The medical team then communicates with that designated person.
Okay, good to have that clear definition. Let's touch on another critical area, protecting vulnerable patients. Standard 10.1.8?
Yes, this requires documented procedures specifically for safeguarding patients, especially vulnerable ones, from abuse and harm. Safeguarding is framed as a collective responsibility. The glossary defines it as protecting health, well-being, human rights, living free from harm, abuse, neglect, essential for quality care.
And who's seen as particularly vulnerable here?
Well, abuse can affect anyone, but the guidance highlights groups like the elderly, the frail, and adults and children with disabilities as being at particular risk.
And there need to be clear steps for staff if they suspect abuse.
Yes, procedures must outline exactly what action staff should take if they suspect abuse or see evidence of harm, often following national safeguarding laws.
Right. So finally, how do these standards make sure staff can actually do all this? Training comes up in 10.1.14.
Training is absolutely key. Staff need training on the patient agreement itself, what it means, but also, crucially, how to communicate effectively with different patient groups, including patients with diverse needs or disabilities, to make sure their rights are met in practice.
What does that communication training look like?
The guidance says staff need to understand the agreement well enough to explain it. Communication needs to be suitable for the patient's understanding, maybe using pictures, recordings, videos. It explicitly mentions thinking about special needs, like how to communicate well with someone who is hearing or visually impaired.
And just making the information available is part of it too, right? Standard 10.1.13.
Exactly. Centers need to show they provide info on patient rights in different ways. The guidance suggests leaflets, posters, pictures, the website. Multiple formats help make sure people are actually aware.
Okay, wow. We've covered a huge amount from these standards.
Yeah.
Stepping back from this deep dive, what are the really big themes that jump out about patient rights in accredited centers?
I think what really comes through is this strong commitment to dignity, not just as a word, but in everyday practice. A huge focus on clear, tailored communication, making sure you understand. Recognizing individual needs, especially for vulnerable patients, is central. Robust safeguarding procedures, too. And fundamentally viewing the patient as empowered through information, participating in their care, but also having responsibilities.
Yeah, understanding these standards definitely gives you a clearer picture of what accredited centers are aiming for and, frankly, what you have a right to expect.
It moves beyond just a vague idea of patient rights to really concrete requirements.
Absolutely. So this deep dive into the standards shows a very detailed picture of rights, responsibilities, and procedures. But it does leave you wondering, doesn't it? How consistently can the day-to-day reality of a busy hospital or clinic always live up to these written ideals? And what role does the informed patient, knowing these rights, actually play in making sure they're upheld?